Alrighty guys, so this is a longer slideshow, and so I'm going to go through some of it pretty quickly because while it's important to know these things, especially if you're going to work in a population where you're going to see pregnant women frequently or patients with pelvic floor dysfunction, this is very important information to know, but I'm going to go over the highlights of what you need to know for the boards to limit your confusion. Focusing in on the videos that I posted online as well, those are specific for your boards, and you will see a lot of emphasis on incontinence, and so that is an important concept to understand all the differences of. This lecture comes from two different textbooks. It's going to be your Therex 1 textbook, Kisner and Colby, and your Mansk Ortho book. So let's get started. Chapter 25 in Kisner and Colby is going to be the first one that we'll roll through. So characteristics of pregnancy, we're going to have an average pregnancy is 40 weeks, but a normal term pregnancy is anything from 38 to 42 weeks. Symptoms that may be exhibited during pregnancy are going to be mother fatigue, frequent urination, nausea and or vomiting, increased breast size, relatively small weight gain of 0 to 3 pounds, emotional change by the end of the 12th week. Fetus is growing 6 to 7 meters long and can kick, turn its head, swallow, and has a heartbeat. So that's going to be all within the first trimester that we're seeing those changes. Second trimester starts after the 12th week, so runs 13 to 26 weeks. Pregnancy becomes visible to others. Mother usually begins to feel movement around 20 weeks. Most women feel better during the second trimester, and so nausea and fatigue usually disappear by the end of the 26th week. The fetus is 19 to 23 centimeters and weighs 1 to 2 pounds, has eyebrows, eyelashes, and fingernails. Third trimester starts after the 26th week, so weeks 27 to full term. The uterus is now large and has regular contractions, although only some of them are felt by the mom. Common complaints are frequent urination, back pain, lower extremity edema, fatigue, pain from the round ligaments that suspend the uterus, shortness of breath, and constipation. By birth, the baby is 16 to 19 inches long and weighs approximately 7 pounds. Labor happens in 3 different stages, and so we get hormonal changes from both the mother and the baby that trigger labor to start. Changes that occur in the cervix include effacement, which is shortening or thinning of the cervix from a thickness of 5 centimeters to a thickness of a piece of paper, and then dilation, which is opening of the cervix from the diameter of a fingertip to approximately 10 centimeters. Stage 1 is further divided into 3 major phases, where we have the cervical dilation phase, the middle phase, and the transition phase, and these are just all the progressive increases in cervical dilation. Stage 2 involves pushing and expelling the baby. There's intra-abdominal pressure is the primary force in delivering the baby, produced by voluntary contraction of the abdominal muscles in the diaphragm. Relaxation and stretching of the pelvic floor during stage 2 is necessary for delivery. Contractions may last as long as 90 seconds during this stage, and you can see page 1022 in your Therex 1 book for a reference of the fetal descent. Stage 3 is when the expulsion of the placenta occurs and the uterus continues to contract and shrink after the delivery, causing the placenta to detach and be expelled. And this occurs 5 to 30 minutes after the delivery of the baby, so the placenta does not always come out with the baby. A hematoma forms over the uterine placental site to prevent further blood loss, and vaginal bleeding persists for 3 to 6 weeks after delivery. And we need to be mindful of that in treating patients postpartum. Uterine involution is where the uterus continues to contract and decrease in size for 3 to 6 weeks after delivery. The uterus never returns fully to pre-pregnancy size. Anatomical changes that occur during pregnancy, typical weight gain should be between 25 and 35 pounds. That is normal, healthy weight gain for a single baby in pregnancy. You will see variations amongst individuals, and we want to be patient specific, but knowing that average of 25 to 35 pounds is important for the boards. Changes that we'll see in organ systems are that the uterus and related connective tissue increase in size and weight. The muscle cell in the uterus increased by 10 times its original size by the end of pregnancy, and ligaments connected to the pelvic organs are more fibroelastic than their joint ligaments, and they tend to suspend and support the uterus, and patients can experience pain due to irritation of these ligaments. Because of the angle of the ureter entering the bladder, the kidneys are affected with an increased risk of urinary tract infection during pregnancy because of the position of the uterus. The pulmonary system is affected by decreased space for the ribs to move due to the visceral organs being pushed up into the thoracic cavity. And so dyspnea is present with mild exercise as early as 20 weeks into pregnancy. Cardiovascular system has a blood volume increase throughout pregnancy, and increases in plasma volume occurs. There's a venous pressure in the lower extremities that increases during standing due to increased uterine size and increased venous distensibility. Pressure in the inferior vena cava rises in late pregnancy, especially in the supine position because of compression by the uterus. The aorta is partially occluded in supine in late pregnancy, and so we want to make sure that we don't lay a pregnant woman in supine in later pregnancy. Typically, after the first trimester, we don't want to have a patient spend more than 5 minutes in supine. Blood pressure decreases early in the first trimester, reaches its lowest level midway of pregnancy, then rises from mid-pregnancy to reach pre-pregnancy levels about 6 weeks after delivery. Blood pressure decreases due to the increased venous distensibility in the initial stages of pregnancy that persists before the body finds a homeostasis for maintaining blood pressure. The heart size increases and the heart rhythm disturbances are more common during pregnancy. Heart rate increases 10 to 20 beats per minute by full term and then returns approximately 6 weeks after delivery. Cardiac output increases 30 to 60% during pregnancy and is most significantly increased when the mom is in left side lying position because this position puts the least pressure on the aorta when pregnant. Musculoskeletal systems are going to be important for us to know during pregnancy and following pregnancy because that's going to be an area where we're going to be most likely to treat the patient. So the abdominal muscles in the linea alba are subjected to significant biomechanical stress and become stretched to the point of their elastic limit. The pelvic floor drops by as much as 1 inch by the end of pregnancy and must support a great deal more weight. The hormonal influence on ligaments is profound, decreasing ligamentous strength and increasing joint laxity. This is related to the increased levels of relaxin, estradiol, progesterone, and cortisol in the blood. And so that increased ligamentous laxity decreases joint stability and causes patients to have an increased presentation of pain. These physiological changes lead to increased risk of injury in weight-bearing joints of the back, pelvis, and lower extremities during pregnancy. The thermoregulatory system is affected because metabolic rate and heat production increase during pregnancy. A mother requires 300 more calories per day to meet basic metabolic needs, and pregnant women have a lower fasting blood glucose level than non-pregnant women, meaning that they are more likely to exhibit signs of hypoglycemia. Changes in posture that occur include that the center of gravity shifts upward and forward due to enlargement of the uterus and breasts. The lumbar and cervical lordosis increase to compensate for this shift in center of gravity. We also get a resulting shoulder girdle and upper back that becomes rounded with scapular protraction and upper extremity internal rotation due to breast enlargement. This postural tendency persists during postpartum due to breast size and infant care demands, and so can be a postural abnormality that we have to treat in the clinic. The suboccipital muscles work hard to maintain optical writing reflex with the forward head posture, and so we get fatigue and headache onset from suboccipital tightness. Women who are pregnant demonstrate a tendency to fall into genu recurvatum, which will shift the weight towards the heels to counteract the anterior pull of the growing uterus, and so enhancing stability at the knee joint. Postural changes don't always disappear after pregnancy and may become habitual, and so even a woman who is several months to a year postpartum can have issues with these postural changes because of a result of their pregnancy and the habits they form during that pregnancy. Movement of the center of gravity is obviously going to cause changes in balance, and so compensation for this is a result in wider base of support and increased external rotation of the hips to create greater stability. We need to pay attention to balance activities, but make sure that we exhibit sufficient caution that we avoid falling so that we don't have a pregnant woman fall on her uterus. There are pictures of these muscles later on in this slideshow, and so I'll wait till you can look at those to talk about them anymore, but the pelvic floor is a funnel-shaped group of muscles that helps to support all of the visceral organs, and they create a superior upward force and a puckering or drawstring motion around the sphincters for both urinary and bowel control. So here are some of the pictures where you can see that funnel shaped, And it's the levator ani muscles that we are most commonly trying to strengthen when we look at pelvic floor training. The female pelvic floor allows for passage of a baby through the pelvis and passage of the urethra, vagina, and rectum. There's less intrinsic stability and pelvic organ support when compared to the male anatomy due to this. And so female are at a greater risk for pelvic floor dysfunction, but they are not alone in that population. The levator ani nerve and pudendal nerve provides nerve supply to the perineal tissues. The pelvic floor musculature provides support to the pelvic organs, withstands increased intra-abdominal pressure, helps to stabilize the spine, pelvis, and includes sphincteric control of the urethra, vagina, anus, and aids in sexual response. Neurological compromise, so stretch and compression can occur on the pudendal and levator ani nerves during labor with birth of a baby's head, and so we need to understand that there is potential damage with the effects of childbirth. We can also see muscle impairment from stretching of the muscles during childbirth, and then the effects of episiotomy, which is a surgical incision made to the perineal body to enhance the opening for childbirth. So male pelvic floor dysfunction, the primary contributing factor is prostate enlargement or prostate cancer treatment. Diastasis recti, we've talked about a little bit, but it's a separation of the rectus abdominis muscle at the midline of the linea alba, and it's any separation larger than 2 finger widths is considered significant. Condition is frequently seen in childbearing women, but can affect others as well. It can affect up to 66% of women in the 3rd trimester of pregnancy, and it can be at increased risk because of the hormonal effects on the connective tissue and the biomechanical stresses. It doesn't usually cause discomfort. It can occur above, below, or at the level of the umbilicus, and it appears to be less common in women with good abdominal tone before pregnancy. So this is a picture of a diastasis recti. The diastasis recti may produce musculoskeletal complaints such as low back pain because the integrity of the abdominal wall has been compromised for providing support to the lumbar spine. Activity limitations such as difficulty with supine to sit can occur, any of those transitional movements. In severe separations, the lack of muscular support provides less protection for the fetus. Potential for herniation of the abdominal viscera through the separation of the linea alba can occur. We want to make sure that we test all patients for diastasis recti prior to prescribing abdominal exercises, but especially pregnant women. So we do this by placing our patient in hook lying, have the patient slowly raise their head and shoulders off the table, reaching their hands toward their knees until the scapulae clear the table. Place the fingers of one hand horizontally across the midline of the abdomen on the umbilicus, so this is you as the therapist. If a separation exists, the fingers will sink into the gap between the rectus muscle, or a visible bulge between the rectus bellies can be seen. You're going to document the number of fingers that can be placed between the muscle bellies and document what level it is at. So this is a picture of that herniation. Back pain is reported by 50 to 80% of pregnant women at some point. Symptoms are usually worsened with muscle fatigue from static postures or as the day progresses. We want to treat with traditional low back exercises, proper body mechanics, postural corrections, improvement in work techniques. So thinking back to spinal rehab exercises, but also trying to be considerate of your positioning. Do not use deep heating agents or e-stim near the low back or traction during pregnancy. SI pain is localized to the posterior pelvis and described as a deep stabbing pain in the buttocks distal and lateral to L5-S1. There's pain with prolonged sitting, standing, or walking, climbing stairs, turning in bed, unilateral standing, or torsion activities. Pubic symphysis dysfunction may occur and includes a significant tenderness to palpation at the symphysis with radiating pain into the groin and medial thigh and pain with weight bearing. We want to modify or eliminate activities that aggravate pain, use stabilization exercises, and the use of an SI belt or corset to help provide increased stabilization. Activity modifications that we will teach patients will include things like log rolling techniques, having them side lie with the pillow between the knees, but on the left side, not the right side. Modifying sexual positions to avoid full range of hip abduction, avoiding single leg weight bearing, and avoid crossing legs and sitting or standing or swinging one leg out of bed at a time. Exercise modification for pelvic pain during pregnancy. We want to have patients avoid exercises that require single leg weight bearing and excessive hip abduction or hyperextension. So no single leg stance, try to limit our single leg activities. Teach the patient to activate the pelvic floor and the transverse abdominals when transitioning from one position to another and with any lifting. This co-contraction will help not only coordinate the pelvic floor activation, but provide enhanced stability to the pelvic floor and lumbar spine. Varicose veins are another thing that can happen to women during pregnancy. They may become more susceptible to DVTs as a result of varicose veins. We can educate patients on positioning and also to wear elastic support stockings. Joint laxity, patients have an increased risk of injury to joints during pregnancy and postpartum. The tensile quality of ligamentous support is decreased because of those hormonal changes. The elevated levels of hormones have been found 3 to 5 months after delivery, so giving birth to the baby does not mean that hormone levels return to normal. Elevation may persist even longer when the woman is nursing, and so we need to consider the effects of breastfeeding. Make sure that you modify exercises to reduce joint stress and suggest non-weight-bearing aerobic activities such as swimming, walking, or stationary biking. I know walking isn't a non-weight-bearing aerobic activity, but it's at least less jarring aerobic activity, and so that's why it's on this list. Postural and hormonal changes result in increased nerve compression syndromes during pregnancy. We want to make sure that we begin pelvic floor exercises with an empty bladder. We may need to start with gravity-assisted positioning for clients with extreme weakness, and then explore other positions, and finally implement with functional activities. We can utilize interventions like contract relax, where we instruct the patient to tighten the pelvic floor as if stopping urination mid-flow or holding back gas. We want to have them hold for 3 to 5 seconds and relax for an equal length of time. Repeat up to 10 times. As the pelvic floor muscles fatigue, patients will start to recruit their glutes, abs, and hip abductors to compensate. Don't let them do this. We want to focus on pelvic floor activation. We also want to watch the patient for the Valsalva maneuver and correct that as needed. We can also implement quick contractions, where we have the client perform quick, repeated contractions of the pelvic floor while maintaining a normal breathing pattern, and we want to shoot for 15 to 20 reps per set. Elevator exercises are where we instruct the patient to imagine the pelvic floor as an elevator. We want to take the pelvic floor up one floor at a time and then down one floor at a time. This requires a concentrated eccentric contraction and is very challenging for the patient. Pelvic floor relaxation can be done by instructing the patient to contract and then allow a total voluntary relaxation. We can use the elevator analogy to ask the patient to take the pelvic floor to the basement. Relaxation is linked with effective breathing and the relaxation of facial muscles. So we need to make sure that our patient isn't scrunching their face, that they have normal breathing patterns. Chronic inability to relax the pelvic floor muscles may lead to impairments such as pelvic floor overactivity and pain with intercourse or voiding dysfunction. So we want to make sure that as much as we need to strengthen the pelvic floor in the majority of our populations, if a patient has an overactive pelvic floor, we need to teach them how to relax it. And we can use things like EMG feedback or biofeedback for down training of this. We can use hip rotation to help increase the stability of the pelvic floor, instructing the patient to sit tall with their feet on the floor. They can move their knees in and out for non-resisted internal and external rotation. To add resistance to external rotation, we'll throw a resistance band around their knees. For resistance for internal rotation, we can put a ball between their knees. It's important that you remember the link between the pelvic floor and the multifidi and the transverse abdominis, and that we have coordinated activation of all of those. We have the best stability of the pelvis and spine. So when we are exercising a pregnant woman, we want to make sure that we pay attention to the maternal response to exercise. So blood flow aerobic exercise causes redistribution. So that gives us two concerns. Reduced blood flow results in decreased oxygen and nutrients to the uterus, and it may stimulate uterine contractions. So we want to make sure that we are not pushing our pregnant woman to exercise at a level beyond their oxygen capability. Stroke volume and cardiac output are going to increase to help combat those concerns, but we still want to monitor. Respiratory rate, maternal respiration rate appears to adapt with mild exercise, but does not proportionately increase with moderate and severe exercise when compared with non-pregnant women. Pregnant women reach a maximum exercise capacity at a lower work level than a non-pregnant woman because of the increased O2 requirements, and so we might want to utilize an RPE scale for this patient population. Hematocrit levels are typically lower in the pregnant population, We also remember we want to talk about the risk of inferior vena cava compression and aortic compression, and so we avoid right side lying, we avoid supine positioning longer than 5 minutes, and typically we're going to avoid prone positioning once the patient begins showing. Energy needs, hypoglycemia occurs more readily during pregnancy. Make sure adequate carb intake occurs for pregnant women who are exercising. And vigorous exercise increases body temperature more regularly in maternal women, and so there's been some concern of elevating core temperature with pregnant women due to the link between increased core temperature and neural tube defects, which can cause developmental problems, and so we want to pay attention to overall body temperature while exercising. Vigorous exercise may increase the risk of uterine contractions, and so we want to be careful of that. But in healthy women, regular physical activity has been shown to be beneficial and is recommended for pregnant women. Moderate intensity, so 12 to 14 on that RPE scale, aerobic activity are recommended during pregnancy and postpartum for at least 150 minutes per week, 15 to 30 minutes per day. Women who wish to engage in strenuous or competitive athletic activity should be closely monitored by a physician, so defer that one to the doc. No research has conclusively shown a detrimental response to mild or moderate exercise during pregnancy. Recent studies have even shown vigorous activity not having detrimental effects, but overall the rule of thumb is that if the person was working out before therapy or before pregnancy, they are safe to continue working out after they get pregnant. We don't want to increase the physical demands of somebody who is not working out prior to pregnancy, and so we want to monitor them a little bit more closely. But as far as exercise recommendation goes, if they're doing it before pregnancy, they should be safe to do it during pregnancy. It's important to note that the fetal heart rate generally increases 10 to 30 beats per minute at the onset of maternal exercise, and it takes 15 minutes for it to return to a normal level. And again, remember to monitor body temperature because of the correlation to neural tube defects. Women should participate in mild to moderate exercise for at least 15 to 30 minutes most of the days of the week at an RPE scale of 12 to 14. Avoid contact sports, things that are going to be unsafe for babies, like increased fall risks, high heat, and never exercise to exhaustion. Remember that we've got increased joint laxity, and so we want to use more non-weight bearing exercises as appropriate. Moderate exercise does not impair quantity or quality of breast milk or infant growth, and make sure adequate water intake occurs. Contraindications to aerobic exercise during pregnancy are listed on page 1040, but they include hemodynamically significant heart disease, restrictive lung disease, incompetent cervix or early dilation, vaginal bleeding, placenta previa after 26 weeks, multiple gestation with the risk of premature labor, preeclampsia or pregnancy-induced hypertension, rupture of membranes, loss of amniotic fluid, premature labor, maternal type 1 diabetes, or severe anemia. This is a recommended sequence for exercise for pregnant women. It's found on box 25-6, but you start with a warm-up, add in selective stretching for postural alignment, aerobic activity, postural exercise strengthening, cool-down activities, pelvic floor muscles, relaxation techniques, labor and delivery techniques and position, educational information, and postpartum exercise instruction. This is not a hard and fast, but this is a recommended sequence. For maternal exercise, we want to educate the patient that uterine cramping may occur with activity. This is acceptable as long as it stops when the activity is completed. Do not exceed 5 minutes of supine positioning at any one time after the first trimester of pregnancy to avoid vena cava compression. Do not position pregnant women in right side lying. For supine activities, you can place a wedge or towel roll under the right hip to slightly turn the patient into a 1/4 turn at a minimum to avoid this. But overall, we want to try to avoid the position. Discourage breath holding, break frequently for water breaks, make sure the patient exercises on an empty bladder so that we don't increase stress on the pelvic floor or increase risk of incontinence. Modify or discontinue any exercise that causes pain. Limit single leg weight bearing activities. They can cause low back pain, not LOB, LBP, low back pain, or SI or pubic symphysis discomfort. Avoid ballistic movements and stretching. Use caution with hamstring and adductor stretches as they may cause hypermobility or pelvic instability. And do not hyperextend the hip with back stabilization exercises as this can aggravate lower back pain. Contraindications to any type of exercise include vaginal bleeding, persistent pain, especially chest, pelvic, or low back pain, leakage of amniotic fluid, regular painful uterine contractions that persist beyond the exercise session, decreased fetal movements, persistent shortness of breath, irregular heartbeat, tachycardia, headache, dizziness and faintness, swelling, pain in the calf, you have to rule out DVT, and difficulty walking or maintaining balance. These are our critical areas of emphasis for exercise with pregnant women. We're going to make sure for posture we stretch the upper neck extensors and scalenes, we stretch the scapular protractors, shoulder internal rotators, and levator scapulae. We stretch the low back extensors. We stretch the hip flexors, adductors, and hamstrings as long as no pelvic instability is demonstrated. And we stretch the ankle plantar flexors. We want to strengthen the upper neck flexors and lower neck and upper thoracic extensors, scapular retractors and depressors, shoulder external rotators, trunk stabilizers with precautions for diastasis recti, hip extensors not past neutral, knee extensors, and ankle dorsiflexors. So if a diastasis recti is present, we're only going to use these two exercises for abdominal strengthening until it is corrected, or less than 2 centimeters at least. So we have the head lift, where we have the patient hook lying with their hands crossed over their midline for support, like they're approximating the rectus at the linea alba. And we want to have them exhale and lift their head, and then slowly lower their head as they relax and inhale. And then the other part of that we can have them do is adding in a pelvic tilt. So they hook lie, arms crossed to approximate the rectus at the linea alba, lift the head, and then perform a posterior pelvic tilt while they're lifting the head, so that we are training the spine from 2 different directions. Once the separation is less than 2 centimeters, you can add in additional abdominal strengthening exercises, but these are the only abdominal strengthening exercises you want to do if the diastasis recti is greater than 2 centimeters. Stabilization exercises, we want to use typical spinal stabilization exercises and progressions, just considering positioning. Make sure your patient doesn't hold their breath. Maintain a relaxed breathing pattern, and do not progress any abdominal exercise until diastasis recti is reduced to less than 2 centimeters. Pelvic motion training exercises include a pelvic tilt and quadruped. You can do the pelvic clock, where the patient's in hook lying. You have them visualize a clock face with the umbilicus at 12, the pubic symphysis at 6, and begin movements between 12 and 6, 3 and 9, and then arcs from 12 to 3 and 6 to 9 and back. You can do slow to have control of the motions, and then increase speed. And pelvic clock can progress from arcs that go them 12 to 6, and then arc all the way clockwise, and then all the way counterclockwise. And then we can also use trunk curls. Trunk curl ups and curl downs should not be used during pregnancy, but following pregnancy, when we're trying to enhance that spinal stability, we can add those in. No diagonal sit-ups for pregnancy either. Modified upper and lower extremity strengthening can include standing push-ups, supine bridging, quadruped hip extension, don't extend the hip past neutral, modified squatting, and scapular retraction exercises. Perineum and adductor flexibility can include self-stretching for the adductors, where you have them sit with their legs apart and they lean their chest forward. Sitting on a stool, they again can stretch their legs apart and lean the chest forward. Helps to prepare for flexibility needs for labor and delivery. Relaxation exercises can include visual imagery, muscle setting, where you have the patient contract and then relax all of the muscles in their body from the toes up to the head. Selective tension is where they selectively activate certain muscles while focusing on keeping other areas relaxed. And breathing exercises all can be used to induce relaxation. Unsafe postures for exercise in pregnancy are important to know, so that you don't implement exercises or positioning with pregnant women with these. So we want to avoid a bilateral straight leg raise. We're not going to do the fire hydrant exercise for them. We don't want to do quadruped with hip extension past neutral. We're going to avoid unilateral weight bearing activities, and we don't want them supine for more than 5 minutes after the first trimester. Moving on to your ortho textbook in Mansk chapter 27. So the pelvic floor, we know what it does. You can review that if you would like. The anatomy of the pelvic floor consists of 3 layers of muscles. Remember, the levator ani is the one that we are working to activate through most of our pelvic floor training. So here we can see a couple of visuals of the pelvis and pelvic floor and how it helps to create the 2 sphincters to close for urinary and bowel control. Same thing here. Same thing here. So the deep urogenital triangle lies on the internal surface of the urogenital triangle, and consists of the deep transverse perineal muscles, urethral sphincter, and inferior fascial layer. The deepest layer is where we are going to be targeting, and so that's the pelvic diaphragm, and that's going to consist of the levator ani and the coccygeus, and then the piriformis and obturator internus muscles of the hip contribute to that deepest layer. And so that's part of why those hip internal external rotation exercises are important for pelvic floor function. This layer supports the bony pelvis and abdominopelvic organs and provides a stabilization for the hip muscles. So overall, just a review of what the pelvic floor does, but knowing the pudendal nerve originates from the sacral roots S2 through S4. So nerve root dysfunction at S2, S4 is going to contribute to pelvic floor dysfunction. That's also why cauda equina is more likely to present with urinary incontinence, because S2 and S4 or S2 through S4 are more commonly implicated. So we know what the pelvic floor does, but the most interesting part of this slide is that the levator ani muscle stretches 259% of its resting length during vaginal delivery. And so that's another contributing reason why pelvic floor dysfunction is more common in women than it is for men. Pelvic floor dysfunction can be caused by childbirth, trauma, pain, or skeletal malalignment. Dysfunctions are categorized as either supportive, hypertonic, incoordination, visceral, or chronic pelvic pain syndromes. Screening that we can do for pelvic floor dysfunction should always occur for pain in the lumbopelvic region. It can be pain from gynecological, gastrointestinal, or urological causes. And the PTA should be on the lookout for red or yellow flags when treating these patients, and you can find that on table 27.2 on page 540. So supportive dysfunctions are going to include incontinence, pelvic organ prolapse, and musculoskeletal dysfunctions, and neurological dysfunctions. So our types of incontinence are important to know and be familiar with, and incontinence is the involuntary loss of urine or fecal matter. And for the most part, when we talk about pelvic floor dysfunction, fecal incontinence is something that patients deal with, but they're also dealing with urinary incontinence if that's happening, because urinary incontinence happens first. So I look at urge incontinence. It's the involuntary leakage accompanied by or immediately preceded by urgency. Stress incontinence is the involuntary leakage on effort or exertion or on sneezing or coughing. Mixed is involuntary leakage associated with urgency and with effort. Nocturnal enuresis is involuntary loss of urine occurring during sleep. Post-micturition dribble is involuntary loss of urine immediately after passing urine, usually after leaving the toilet in men or after rising from the toilet in women. Continuous urinary leakage is just continuous leakage. And so being able to determine the differences in those and how they affect your patient is really important, especially for the boards. It's something that's come up in the last couple of years. And so I would find a way for you to understand what each one of those types of incontinence is, and then understand how that's going to affect a patient. Urinary incontinence is far more common than you would think, and so there is a high demand for pelvic floor intervention, but it's just not as sought out. First off, because people don't know it exists. Second off, because people are embarrassed. Pelvic organ prolapse is an anatomic support deficit of the pelvic viscera that may result in a series of long-term failures of the supporting and suspension mechanisms of the uterus and vaginal wall. So this is where the pelvic organs start to fall out of the pelvic floor. And you can see that age influences its prevalence in women. Risk factors include increased BMI, a history of fetal macrosomia or miscarriages, menopause, previous gynecological surgical operations, history of metabolic disorders such as diabetes. Symptoms include feeling a bulge at the vaginal opening, low back pain, pelvic heaviness, a dragging sensation, a need to replace the prolapse digitally to allow for defecation or urination. It's classified by the stage of severity and by the viscera and anatomic structure that are involved. So cystoceles and urethroceles are anterior vaginal wall prolapse. Enteroceles are apical vaginal wall prolapse. Uterine prolapse or uterovaginal vaginal vault prolapse. And rectoceles are posterior vaginal wall prolapse. Staging of POPs. Stage 0 is no prolapse. Up to stage 4 is going to be the eversion is essentially complete, and it ranges in between there. types, we went over those, but this puts it into a table that I think just makes it a little bit easier for you to study. So we've talked about a decreased activation of pelvic floor here. Hypertonic dysfunction is going to be when we have an increased activation of the pelvic floor. And this occurs when the pelvic floor muscles are in a state of increased tension or a prolonged state of contraction with the inability to relax. The urethral meatus, vaginal interradius, and anus are forced closed and demonstrate difficulty relaxing for normal functional opening. Symptoms of pain, pressure, or ache that is poorly localized in the perivaginal and perirectal regions, lower abdominal quadrants and pelvis, and sometimes down the posterior thigh depending on nerve involvement. Non-relaxing pelvic floor dysfunction is a broad term, and levator ani syndrome is where we have spasm of the levator ani muscles that keep the pelvic floor contracted. Non-relaxing puborectalis causes bowel movement dysfunction and constipation. Anismus is muscle spasm of the anal sphincter and causes rectal and anal pain. Proctalgia fugax is muscle spasm of the anal sphincter that causes sharp, fleeting rectal pain that can last seconds to 20 to 30 minutes and can also occur during the night. It can cause pain syndromes such as coccydonia or urethral syndrome and pudendal neuralgia. It can also cause urinary retention and constipation. Dyspareunia is pain before, during, or after intercourse. Vaginismus is a common cause of dysmenorrhea due to involuntary contraction and spasm of the bobocavernosus muscle. And vulvodynia is chronic vulvar pain. Incoordination dysfunctions is the inability to coordinate the firing between the appropriate musculature. And we can see this with abdominal pelvic dyssynergias, bladder sphincter dyssynergia, pelvic floor dyssynergia. So for example, during defecation, the abdominal wall must contract while the pelvic floor muscles simultaneously relax in order to create enough intra-abdominal pressure to be able to defecate. And so if there's difficulty in coordinating this, function can be impaired. Chronic pelvic pain is pain in the lower abdomen, vulva or vagina, perineum, anus, or coccyx that lasts longer than 6 months. It can be caused by any one of these factors. So therapeutic exercise for pelvic floor dysfunction is going to primarily emphasize Kegel exercises. They are extremely important for pelvic floor dysfunction, and so you need to know how to do them. And we talked about the prescriptions and the patient education on performance on a couple different types of Kegel exercises earlier. But keep those in mind when applying pelvic floor exercises. They are ideal for the treatment of stress incontinence. So type 1 works on holding contractions, progressing the 10-second holds with a 10-second rest in between contractions. Type 2 works on quick contractions to shut off the flow of urine. So we talked about the difference between those holds and those quick contractions earlier. We want to educate our patient to perform 10 to 80 reps every day, making sure that the patient avoids squeezing the buttocks or contracting the abdominals so that we avoid compensations, and educate the patients on incorporating Kegel exercises into their everyday life with activities like lifting, coughing, and all transitional movements. Strength grades for pelvic floor. I'm not going to have you grade them, but I wanted to expose you to them. Exercise prescription for strengthening. Make sure you determine the patient's ability to perform a proper diaphragmatic breath, especially in coordinating with pelvic floor activation. The diaphragm and pelvic floor have been shown to work together to control intra-abdominal pressure. Coordination of relaxing the pelvic floor with inhalation and depression of the respiratory diaphragm is very important to avoid increasing intra-abdominal pressure, especially when we're working on an issue like stress incontinence. So as we contract the pelvic floor, we want to make sure that we are having our patient exhale, and as we relax the pelvic floor, we want to make sure that we are having our patient inhale, so that way the pelvic floor rises, our diaphragm rises. Our diaphragm goes down, our pelvic floor goes down. Determining the type of pelvic floor exercise needed is very important. We have to determine whether to use endurance or quick contractions, as well as whether it's more important for us to have concentric or eccentric contractions for the patient. And it's also important that we use relaxation exercises for hypertonic dysfunction and strengthening exercises for issues related to muscular weakness or atrophy. If we give a patient with hypertonic dysfunction strengthening exercises, we are not going to help address their problem. So if you were given an Oxford scale score, patients with a 0 to 2 on that scale are going to start in a gravity-assisted or gravity-eliminated position. Patients on a 3 to 5 are going to use gravity-resisted positions. If you don't have an Oxford scale score, then you're going to know a patient who has less strength should start in a gravity-assisted or gravity-eliminated position. A patient who has more strength should start in a gravity-resisted position. So gravity-assisted positions, these pictures show some examples of what that might look like for pelvic floor activation. These pictures show gravity-eliminated positions for pelvic floor activation. These are more pictures of gravity-eliminated positions for pelvic floor activation. This is another gravity-eliminated position for pelvic floor activation. These are gravity-resisted positions for pelvic floor activation, and you can see the body weight is pushing down, so the thoracoabdominal organs are pushing down on the pelvic floor, and the abdominopelvic organs are going to be placing the most pressure there. More gravity-resisted positions for pelvic floor activation. And then we want to progress our patient to gravity-resisted positions with movement. So we'll initiate stepping up or stepping forward, or squatting, or lunging, all while maintaining pelvic floor activation appropriately. We can increase the resistance with vaginal weighted cones, and so as our patient is able to progress through these transitional movements, if they're having difficulty, we might back them up to a gravity eliminated position, but with a vaginal cone, and work that progression that way. Remember, choose your exercise interventions wisely. If you strengthen a pelvic floor that is shortened or hypertonic and painful, you can exacerbate the patient's condition instead of improving it. Biofeedback can be used for down training as well as relaxation exercises. We want to teach the patient to coordinate the pelvic floor with the respiratory diaphragm. So when the diaphragm contracts with inhalation, it descends into the abdominal cavity, and the pelvic diaphragm should relax and stretch. During exhalation, the diaphragm goes up, and so that's when the Kegel exercise should be performed. With hypertonic dysfunctions, emphasis should be placed on slow inhalation and with a slow stretch of the pelvic floor diaphragm, using diaphragmatic breathing to inhibit pelvic floor contraction. It may also fall to us as therapists to provide stretching of the pelvic floor muscles, and so you can use manual stretching where you instruct the patient to insert their thumb and perform U-shaped strokes in the vagina to stretch out the pelvic floor muscles. Vaginal dilators can also be used to prevent vaginal stenosis after radiation therapy for cervical cancer and pelvic floor reconstruction surgeries. So this is what vaginal dilators can look like. Manual soft tissue and neuromuscular techniques to help with stretching of the pelvic floor can include a contract relax, where the PTA inserts a finger or dilator vaginally and asks for a voluntary contraction of the levator ani muscles, and then applies a gentle posterior stretch on the voluntary relaxation of that contraction. There's also reciprocal inhibition, which uses the abdominal muscles to create a Valsalva maneuver and then have reciprocal inhibition and relaxation of the pelvic floor muscles. So remember, coordinated activation with transverse abdominis should happen with pelvic floor activation, but rectus should activate when the pelvic floor is relaxed. Trigger point release can use of ischemic pressure at the localized painful nodule. And then strain counter strain is a technique of passively positioning a patient in a shortened position to allow the muscle spindle to reset and break the muscle contraction cycle. Modality considerations for pelvic floor dysfunction include EMG biofeedback, which can be used for up training or down training, depending on what the patient's needs are. You can also use E-stim for pain control or muscle strengthening, but we have contraindications for pelvic floor E-stim, and those include pregnancy, patients with pacemakers, active vaginal or rectal infection, active vaginal or rectal bleeding, and impaired sensation. And in connecting this with everything else that we've learned, incorporating pelvic floor exercise is vital when treating patients with low back pain due to the relationship between the pelvic floor and the deep spinal stabilizers. So when we're talking about transverse abdominis and the multifidi muscles. Consider pelvic floor treatment as essential also when you're treating hip dysfunctions such as THA or hip fracture repairs. Sciatica and piriformis syndrome are the radicular symptoms in sciatic nerve distribution, and we need to remember that this can be caused by compression of the nerve through the piriformis. Pain mimicking this can be caused by the obturator internus dysfunction because piriformis and obturator internus both contribute to the pelvic floor. And so we need to make sure that we identify the appropriate dysfunction and address the patient's symptoms with the correct targeted intervention. And then SI joint dysfunction is likely due to malalignment or abnormal movement of the SI joint because of insufficient support and stability. And so we need to make sure that we incorporate pelvic floor activation in with those patients as well. That is it on pelvic floor. And I know it was a whirlwind, but hopefully I consolidated it to what should be the most important things.